Let's talk occlusion part 2, the bonded prototype. I want to make sure that everybody that is here with us knows that we are back into our hands-on courses. Our next hands-on course is going to be our master class on porcelain veneers, and it would be held in Atlanta, Georgia, this coming September 16 or September 16. You can choose from both of those sessions. There's only 15 seats available per session. For Friday, I think that we still have 10 seats available. For Saturday, September 16, we only have 4 seats available. So if you have any interest in being part of this whole day seminar, where you will get 9 hours of continuing education credits and learn a step-by-step protocol to really master porcelain veneers, please join us in September. It's either September 15 or September 16 of this year in Atlanta, Georgia. It's very easy. We're going right now with an early bird, and it's early bird discount, and it's very easy to register to this meeting. If you want to register to the meeting, all you have to do is visit our webpage, www.romerodentalseminars.com, and click on the link seminars and just hit on the Atlanta September 2023, and it'll walk you through the process of you registering for the course. We also want to thank Colteen, Oral Arts, Dental Laboratories, and Romero Dental Seminars for allowing us to provide 1 free CE credit for this live webinar. At the end of the webinar, you have to visit our webpage, www.romerodentalseminars.com, click on the link webinars, and then click on the link CE quizzes. You will then download the quiz, answer the 5 questions, add your information, and email it to us at romerodentalseminars@gmail.com. We will make sure to submit your CE credits to the Academy of General Dentistry. We also want you to visit our YouTube channel, Romero Dental Seminars. All our webinars are recorded live, and then they are uploaded into our YouTube channel. So if you haven't visited our YouTube channel, you will find that there's a lot of very, very good information within our channel. We have 37,000 subscribers, and we have videos that have been watched over 1 million times. So please make sure to visit our YouTube channel, subscribe to our channel, and take advantage of all the webinars that we have there for free for you to access. Our learning objectives for today, and again, this is our second part. So if you were not part of part 1, I would highly recommend that you watch our part 1 webinar on occlusion. That one had a specific learning objectives. Our specific learning objectives for today are: after viewing this webinar, the participants should be able to complete a thorough clinical examination, identify the signs of instability clinically, understand when restoring in centric relation is a must, identify the clinical steps for a bonded prototype, and understand when the Dahl effect should be considered. So let's talk about clinical evaluation. So in my mind, one of the most important things that we can do in clinical practice is definitely gather information and analyze this information for our decision-making tree when it comes down to clinical decision and treatment planning presentation to our patients. I like to include in all my larger cases good high-quality dental photography, which I think is essential not only for us to view and to understand, what is the patient going through and what would be the best way for us to solve their problem, but also so that when we are presenting the case to the patient, it makes it easier for them to understand. I hear this all the time. A lot of people talking and taking courses about, selling dentistry and selling this and selling that, and I really don't believe it. I don't like even using the word selling. I like using the word, let's inform our patients. Let's give them the information. Let's show them what's going on with their teeth, with their stomatognatic system throughout our photography and throughout our clinical evaluation, and let them make the decision. We can give them the advice, We can tell them this is the way that I suggest that we would go. You always want to, you always want to make sure that you're giving them the best option. But it's also very, very important for them to understand that you did everything, you took everything into consideration at the time of making your final decision. So having a good presentation definitely makes a world of a difference. And that's the first part that I'm going to share here with you. I'm going to share with you how I go about getting the information from my patients, taking the photos and making sure that then I can use them to explain to them exactly what is it that I want to accomplish in their particular case. I go with their age and ethnicity. That's very critical and important for me, because based out of the age of the patient, I want to make sure that if there's any wear, excessive wear, erosion, or attrition on their teeth, does it go with their age? Is it normal attrition? Is it normal wear and tear of the teeth? Or is it excessive wear and tear of their teeth that I should be looking into, maybe an occlusal issue or something more complex within their system that is causing this to happen? Do they have dental insurance? Is that dental insurance going to accept in any way my treatment planning? In our practice, we are a fee-for-service practice. We do help our patients, file their claims through their insurance, but they understand that they have to pay us, and then they should go ahead and get reimbursed by dental insurance if the dental insurance considers that they should be reimbursed. I have just found that many of the occlusal issues on our patients are very difficult to get reimbursement from the dental insurance, but that should not prevent you from giving your patient always the best option. The type of patient. Is this a new patient? Is it a patient of record? Is it somebody that was referred? Who referred this patient to you? That's also something that you want to know, because many times you have patients that you've done a lot of dentistry too, that you've helped in a good way to solve their problem, and they can become a source of referral. And that, in my mind, is very, very good, because it also helps that patient coming into your practice knowing that he's going to get good care, and knowing that the best thing that he can do is follow your instructions. So again, this is all about that quote unquote selling thing that you have to have in your practice. But I like calling it more, just giving the patient the information, giving them the choices, and making sure that they understand those. What's the reason for the visit of the patient? That's also something that I always want to ask, because I want to make sure that I'm taking into account their chief complaint, and that I'm going to satisfy with my overall treatment planning their chief complaint. So this patient had noted that some of his teeth had moved. He literally was complaining about a midline diastema, a very small midline diastema that was present between 8 and 9, that he did not recall having present in years prior. Obviously, the past medical history, if they have any medical issues that we should know about. Are they taking any medications? Today, sleep apnea is just to give you an example, something that's out there that is very common and prevalent in our patients. Some of them use CPAP. Can this problem also generate an occlusal problem? Or what is the relationship between the sleep apnea and the excessive wear occlusal problem? Or maybe anterior open bite, any of the other issues that we may find in our patients. So that's really important for us to know. Our social history. Do they smoke? Do they not smoke? And this is again important, because if you're considering for a patient, placing implants, or doing they have periodontal disease, and then you need to take care of that periodontal aspect before you go ahead and plan anything definitive in their treatment plan. Would that be affected by their social history? So that's very important for you to know. Again, medications, any allergies to medications. If you were to do surgeries, you're going to have to provide patients with some prescriptions. What kind of medications do you want to give them? Do they like taking medications? Today, we have a lot of patients that come to me actually, and say, I'm the kind of person that don't like to deal with medications. I'd rather just, stick to, if it's going to hurt and it's a normal pain, I'd rather just stick to it until it gets better, rather than taking a specific medicine for pain, just as an example. So these conversations, you want to make sure that you have them before you even plan anything for your patient. The other things comes in our patient interview, and I do take my time. I do like to give any new patient at least a full hour appointment, where I want to listen to them also. I want to make sure that I review what I need to review on my side, but I want to sit down and listen to them. And I ask them, what brought you to us? What is your chief complaint? And I write down specifically what the patient tells me. In this particular case, the patient said, I have noted a space between my teeth that was not there before. and I asked him exactly, if he could pinpoint that area, and he pinpointed right between 8 and 9. If you look at the photos on the right hand side, you can see that diastema between 8 and 9. You can also see that tooth number 9 is more tooth number 8, I'm sorry, is more facial than tooth number 9. So number 9 is slightly more lingual. The other thing that I want you to see to these teeth, in these photos, I'm going to mention them in a little bit when I talk about their dental history. But the second chief complaint that the patient had was, I also have some broken teeth that have been restored multiple times and they keep breaking. So immediately this comes to my mind. Okay, did the prior dentist choose the right material? Was there any occlusal problem that they did not, that the prior dentist did not catch? Is the maxillomandibular relationship of this patient the ideal? Is maximum intercruspation in this patient directly related to eccentric relation? Are they the same? If they're not the same, should they be the same? These are all questions that I'm asking myself when I'm listening to my patient just tell me their story. Tell me, why are they here? And again, if you look at the right-hand side photos, you can see on the right-hand side all that excessive wear on the mandibular incisors. Look at the amount of enamel that has been eroded from the occlusal surfaces of the first molars on the mandible and on the maxilla. You can see that dentin exposed because of the washout of the enamel. Also, I want you to look at the cingulum or the lingual surfaces of 8 and 9, 7, 10, and 6 and 11. You can see that there are normal cingulums. Look how smooth and flat the lingual contours of these teeth are. And that is an erosive issue. That is, we know that this patient is having either an acidic diet or is having GERD, and something is eroding, that acid is eroding this enamel away from the teeth. And this is now obviously creating a change or modification in the patient's occlusion. So this is something that we need to know. And the only way that we can observe this, we're not going to be able to observe every single detail of this specific clinical issues with this patient just by talking to them or looking into them intraorally in that first appointment. So this is when taking dental photography becomes extremely critical, because then you can sit down on your computer, you can you can review your notes, look at the photos, and start coming up with ideas and solutions of why this is happening and what can I do to prevent it from continuing to happening. On the dental history side, he had some occlusal composites that were there for more than 20 years on teeth number 3, 14, and 19. And, they were all in good conditions. Orthodontic treatment had been completed 2 times, but as a teenager. So this is something that also comes into mind. He had orthodontic treatment done 2 times. Why did he stop the first time? Why did he have to do it a second time? Was it the first time not well completed? And again, you can see that after 2 orthodontic treatments, there's still some space distal between the distal of the mandibular canines and the mesial of the maxillary of the mandibular premolars. So you can see that even though he had completed orthodontic twice in his life, they were not well completed. And that is something that we have to take into consideration, because I have noticed many times in my 20 years of experience that when orthodontic treatment is not correctly completed, some of these patients may end up having what you're seeing here, attrition, excessive wear of their teeth because of a lack of good or stable occlusal holding contacts. Premolars were extracted for orthodontic treatment. Mesial 2 to 3 millimeter diastema left between mandibular canines and premolars, and I already pinpointed out that for you. But again, just looking at the photos, look at the mandibular tori also, which is another thing that I like observing, because I see that all the time on patients that have occlusal problems, on patients that have excessive wear of their teeth. I see this excessive buildup of bone in these areas that obviously, we have to look at them as a sign of something happening in this stomatognathtic system that I need to make sure that I correct. And that clinical oral examination, we look at every single arch, we look at the maxillary arch, we look at the mandibular arch. Again, all existing restorations in the maxillary arch were in good conditions. And this is something that I like, that I do want to make a small comment on, because I hear a lot of people saying that, composites are only good for 5 to 7 years. And some even say 2 to 3 years. Well, these composites have been there for 20 years, 20 plus years, and they're still there, even though this patient doesn't have a stable occlusion, even though this patient has a lot of erosion. You can see that this material that is not a new composite. This is an old version of our restorative materials that we have today. They're still holding on well because they were done well. They were bonded well to enamel, and they just, they're not that large, so that, being a smaller size type of restoration, if they're surrounded more by actual tooth structure, these restorations are going to last as much as any amalgam out there. Enamel erosion was noted, as I said, on the occlusal surface of molars and premolars, as well as the lingual surface of incisors. And on the mandibular arch, we had, again, enamel erosion noted on the occlusal surfaces of molars and premolars, erosion or pathologic attrition noted on 22, 23, 24, and 25, and bilateral lingual tori. The periodontal evaluation was within normal limits. Tissue was pink with stippling. Plaque was moderate. Calca was noted between mandibular incisors. Very, very little plaque. Patient really had no periodontal issues. He was fairly healthy. Again, this is now his smile photos. I like to take these photos from the front, from the left, and from the right. And I just want you to start noting the things and the comments that the patient was making to me while he was telling me about why he was in my office. Number one, look at the midline diastema. Again, he had reported that he had not had a diastema in the midline. His wife was with him, and she also had noted that these teeth were separating. The teeth were not hypermobile, but they had separated, throughout the last, I would say, 5 to 7 years is when he had noted that these teeth were, that he had a space between these teeth. I want you to pay special attention to the little notch that he has on tooth number 8. You can see that incisal wear on number 8. And I also want you to look at the incisal wear, or the cusp tip wear, of tooth number 11. So the canine on the other side was more intact. If you look at tooth number 6, you can see a nice, sharp, slightly worn down cusp tip. Again, not normal for the patient's age. But if you look on the left-hand side, it's completely different. There's more wear and more, I would say, pathological wear when I compare it to the contralateral canine. This is now a retracted view of the case, and I'm just sharing with you all the photos that I obtain when I'm evaluating my patients. And this is in that first appointment. And you can see now the diastema, you can see the incisal wear on 8 and 9, but more noticeable on tooth number 8. I also want you to notice the abfraction, small abfraction on tooth number 11, but look at the larger abfractions on the premolars and molars on the mandibular arch. So these abfraction lesions tell me a lot, because I know that we're having deflective contacts on these teeth when the patient is biting down into maximum intercruspation, causing these teeth to flex and fracturing that very thin enamel on the cervical aspect. And again, it is not enough only to go ahead and restore these areas if you don't eliminate the causing factor. And for that, we have to figure out what is the causing factor. And that's why it is so important that we understand occlusion very, very well. Again, we have this patient, we have a slightly open photo, and I just want you to see the amount of attrition on the mandibular incisors. Not only the attrition, but I want you to also observe the cant. You can see that the attrition is not uniform. It's more towards one side of his mouth, towards the lower left side of his mouth, and is a lot less towards the right side of his mouth. So this is important for us to understand, because this is telling me right now that if I were to do a specific x-ray where I can see the condyles on this patient, most likely I'm going to see one condyle lower than the other. Once these condyles are in centric relation, I don't think that they're ever in centric relation. Just by looking at the photos, I think that they're off centric relation, but I don't think that these condyles are both even in that relationship with the glenoid fossa. And that is something that I can just see by experience at this point in my career, but just by looking at the amount of wear or the excessive wear on one side compared to the other side of the patient's mouth. And again, this seems like a fairly straightforward case. He's got all his teeth. He's got a couple of spaces here and there. Obviously the patient did tell me initially that he didn't want to go through ortho again. He had ortho twice. He's now 50 plus years old. He just doesn't want to deal with that. He wants to know, is there any way that I can get him back to a stable occlusion without having to go through that process? Which is obviously in my mind, I'm a very conservative dentist. It's a little bit on the negative side for me. I would have loved for the patient to tell me if I need to do ortho again, I'll be more than happy to do it, because I know that there are good orthodontists out there that I trust, that I can refer to, and that I can share my occlusal thoughts and my diagnosis with them, so that we can both help this patient, them with their with the orthodontic treatment, me making sure that the condyles are where they need to be towards the end of treatment. The other thing that I want you to see is the crazed lines on tooth number 8 and 9. They're very, you can see them nicely in this photo. You can see how defined they are, and they come from the cervical aspect almost to the incisal, to the middle third of the tooth, and there's a couple on each teeth. And this is telling me that these teeth, every time that this patient is biting down, the lower mandibular incisors are actually crashing towards the lingual surface of 8 and 9, and just creating a little bit of frenemies on these teeth, just moving them slightly, just shaking them. And I can feel it when I put my fingers. They're not mobile, but I can feel the excessive pressure on these teeth compared to the laterals and the canines. And one of the things that I find when I see this is because of that flexing motion on the teeth, you will see these crazed line or fracture lines on the enamel. The good part is that not always these fracture lines or crazed lines are meant to tell us, oh, these teeth are going to fracture. These can be there for many years, because they normally stop at the DEJ. But again, this is something that we want to pinpoint to our patients, and we want to let them know, that we need to do something from an occlusal standpoint to make sure that we can, and I like using this word, equilibrate, so that they understand easily. Equilibrate, meaning I want to have all these teeth, I want to have all the occlusal contacts to be uniform and to be with the same intensity, and at the same time all around the arch. That is our ultimate goal, and I think that all of us here as dentists know that is what we want to try to accomplish. Look at the mandibular arch again, the attrition mainly on both centrals, mandibular central incisors, but look at the laterals, and look at the left hand side of the patient, right hand side of the photo, compared to the left hand side of the photo, right hand side of the patient. Look at the amount of attrition and excessive wear on the lateral and the canine on one side compared to the other. This should catch your attention, because if everything was in quote unquote stable on the condyle areas, all the wear should be nice and uniform, and that's not what we're seeing on this patient. Larger occlusal views, just to pinpoint the most important aspect for me at this point, is the loss of the lingual contours of the maxillary incisors. You can see how flat they are. Actually, they appear to be prepped with the burr. I can see this very nice margin going all around the gingival margin, coming up from the mesial all the way down to the distal. They look that they were prepped, and this is very common to see on patients with acid erosion, not to mention the way that he has eroded his enamel on the mandibular first molars and the premolars. So, always think about this and look at it, because this patient actually, once I had him look and look at his photos, he literally told me that yes, he does suffer from GERD, that he takes just over-the-counter medications to try to alleviate it. He doesn't have it every single night, but he does have it frequently. So this is another thing that we did. We were able to send him to a gastroenterologist to make sure that they can take care of that aspect while we're taking care of our part, the dental part. But this is how we start helping patients in multiple ways, and not only looking at their teeth and thinking that we're going to be able to solve all the problems just by doing dentistry. Because if we don't take care of that specific aspect of this patient, we're really not stopping the causing factor. We're really not, there is no cure. We're not curing this patient. We're just alleviating him just throughout some dentistry that we can do for them. So what is our clinical summary here? Again, there are signs of occlusal instability, and I want you to again watch our webinar part 1 in relationship to occlusion. We know what the signs of instability are. We know that there are excessive wear, hypermobility, hypersensitivity of teeth. We have all this in this patient. He has excessive wear. He has some teeth that have been moving slowly but surely in the last 5 to 7 years, and that is in relationship to the position of 8 and 9. He has enamel erosion, so he has modified the anatomy of his teeth through that enamel wash, and we have to make sure that that we understand that this is something that we need to incorporate into our treatment plan. That erosion is accompanied by attrition of the opposing incisors. we've done an occlusal exam on the patient. And our initial occlusal exam is very simple. And again, I want you to watch our webinar part 1, where we do we palpate the inferior lateral pterygoid muscle. We make sure that if we find any discrepancy between centrigulation and maximum intercuspation, we want to make sure that both condyles can support complete load with the load with the interarticular disc correctly aligned, so that there is no pain or tenderness in any of the muscles while we are loading the condyles. This is all part of my occlusal exam, and it's very, very critical. So we knew that in regards to pain and tenderness, we noted pain and tenderness on the right inferior lateral pterygoid muscle for this patient upon palpation, and we also noted a discrepancy between centrigulation and maximum intercuspation. And all this is written down, and then when we meet with our patients, we make sure that we explain all this to them. So what are the treatment plan questions that came up through this clinical evaluation that I did of this patient? So the first one was, how am I going to deal with the maxillary midline diastema? Because the teeth were not mobile, and this was one of my patient's chief complaint. The second question I had was, is it necessary to correct the enamel erosion on the lingual of 6, 7, 8, 9, 10, and 11? And if the answer to that question is yes, how do I restore these teeth? And how do I restore what we call the envelope of function? Because don't forget that when we're talking about occlusion, the relationship of the mandibular incisors, the incisal edges of the mandibular incisors, with the lingual contours of the maxillary incisors is what we call the envelope of function. And that envelope of function is the one that's going to allow our patients, when they move forward towards an edge-to-edge position, having all their posterior teeth disocclude. So this is important because his envelope of function has been modified throughout excessive wear and throughout the erosion. The next question that we had is, how would you restore the fractured mandibular incisors? What do we do for these teeth? The other question, and the final one that I have, is what occlusal relationship would you use? Are we going to leave this patient in maximum intercuspation? Are we just going to ask him to open and close, and that's what we're going to use as our treatment occlusion? Or are we going to use centrigulation? And if we are going to use centrigulation, how would you obtain centrigulation? So these are all critical questions that you have to have answers for when you're dealing with cases like this. So the next part of my presentation is going to be, let's talk about when to restore in centrigulation. Because I am going to restore this patient in centrigulation, and I want to give you reasons why I'm going to make that decision. And for me to give you reasons for this, I'm going to go into the literature, and this is a very nice interview that Inside Dentistry had with I think, 3 very big mentors in the area of occlusion. This was published in 2017, and it was an interview with Dr. Dean Coyce, Dr. John Cranham, and Dr. Michael Flynn. And they all were asked the same question: when do you restore in centrigulation, and when do you not? And I just want to take you through the answers. I'm not going to read the entire answer, but I am going to read literally some of the things that they said, because I don't want to put words in their answers. So Dr. Coy said, clinically, I utilize centrigulation when maximum intercuspal position is unhealthy. In other words, there is occlusal disease. When it is unreliable, patients does not have stable tooth contacts. And when occlusal vertical dimension is being altered, all teeth in at least one arch are being treated. So think about that. Think about my patient. If you remember, or you remember right now the photos, all the information that I just gave you in that very thorough clinical examination, my patient falls into all these categories. His intercuspal position is unhealthy, is unreliable, and I do plan to alter his vertical dimension in order for me to treat this patient. So immediately I know that centrigulation is the way to go for my patient. Now let's go to Dr. John Cranham's answer. In the Dawson philosophy, there are two reasons that we make a decision to fundamentally change the occlusion. The first is when there is evidence of occlusal disease, where mobility or migration of the teeth are the primary indicators. While there can be other causes of increased forces to the teeth, these conditions, known as signs of instability, should trigger us to study the patient's occlusion to determine the cause. Again, my patient falls exactly into these categories. And this is in agreement with Dr. Coy's. This patient has what we call an occlusal disease. He's got signs of instability that I've shared with you through my photos. And I know that under these conditions, I'm not going to be able to solve this problem. I'm not going to be able to eliminate the causing factor. The only way that I can eliminate the causing factor is by obviously modifying his occlusion, restoring it to that new occlusal position, and then making sure that the effect was eliminated through the dentistry that I did for this patient. And finally, Dr. Michael Flynn, his answer was, to understand when someone should be restored in centric relation, an evaluation of restorative needs and evidence of occlusal disease must also be considered. Symptoms of occlusal disease may include wear, fractures, cracks, fremitus, mobility, dentin exposure, abfraction, tori, joint pain, muscle pain, recession, or loss of vertical dimension of occlusion. Again, when I read his answer, this is 100% my patient is being identified by what he is saying. So the answer to you and the answer to my question on what should be the ideal condylar position for the rehabilitation of this patient, the answer is centric relation, and it is because of the reasons that I mentioned you at the beginning. Signs of instability, unhealthy occlusion, unstable temporomandibular joints. So now that we know exactly what position, what condylar position we're going to use to rehabilitate this patient, let's talk about the diagnostic waxup. This diagnostic waxup should now have everything, all my considerations built into it. And in this particular case, I'm going to try to simplify this case by using two different theories. The first one that I shared just with you is centric relation. I'm going to make sure that I'm going to wax this case up. I mounted my cast in centric relation. I'm going to wax them up with the condyles in centric relation, and I'm going to share with you the way that I do this. What I'm going to consider initially for this case is I'm going to wax initially my anterior guidance. And the reason why I'm doing this is because I know that there has been change in the anatomy of the lingual surfaces of the maxillary incisors and the mandibular incisors. In other words, there have been changes in the envelope of function, and I'm going to reestablish that envelope of function because anterior guidance is crucial to temporomandibular joint health. I need to have that anterior guidance so that I can allow this occlusion of every posterior tooth when the mandible moves forward and every posterior tooth when the mandible goes left and right. So here are my centric mounted cast. And I am now, once they're mounted, I'm just verifying the canine guidance on the patient. Even though he had excessive wear on the left-hand side, the canine guidance and the eminence were still guiding to create this occlusion of the posterior teeth. So what I did is I increased the vertical dimension. I elevated my pin 2 to 3 millimeters, and I started creating my wax up. I needed room in order for me to restore that envelope of function. Because don't forget, there was attrition and erosion of this envelope of function. So I increased the pin so that I have room to create the wax up and reestablish that anterior guidance and that envelope of function. And don't forget, the envelope of function is that relationship in between the incisal edges of the mandibular incisors and the lingual contours of the maxillary incisors. So you can see here on the left-hand side, I do my own wax ups, and I went ahead and I waxed up the lingual contours from canine to canine on the maxillary arch to redevelop that envelope of function to make sure that I had nice ramps that went all the way from the lingual contours of the canines all the way to the cusped tip. I only had to reestablish or restore one of the cusped tips. The other one was doing just fine and has just minor wear on it. But I also want you to look at how I redid or reestablished all the incisal ledges of the mandibular incisors and both of the canines, so that I can also get nice canine guidance, restore that canine guidance with the anatomy of the lingual contours of the maxillary canines. So with this in mind, what I'm going to do now, I know that I've increased the vertical dimension, and as you noted, I only increased the vertical dimension on anterior teeth, meaning from 6 to 11 on the maxillary arch, and from canine to canine on the mandibular arch. So all that envelope of function has been waxed without any wax up at this point on the posterior teeth. So I'm only going to increase the vertical dimension on the anterior teeth. What do I do next once my wax up is completed? What I do is I make this impression using a clear tray. This tray has no retentive features, no perforations, because you do not want to have any of your clear PVS engaging in the tray. The tray is only there to hold the material in place. I go ahead and seat it on the patient's mouth, make that impression of my wax up, and I'm going to use that clear PVS to fabricate this functional prototype that is what my patient is going to use throughout that initial phase of treatment, which is the diagnostic phase, making sure that my treatment plan, what I have envisioned as a treatment plan, is going to work properly for this patient. And now you can see this is now the impression of the maxillary teeth. This is from canine to canine, just so that I get a nice copy of my wax up and again be able to use it for my prototypes. So now that I have those impressions, that I know exactly what I'm going to do, that I've completed my wax up, let's talk about the bonded prototype. So the bonded prototype is none other than either a very short-term aesthetic prototype or a long-term functional prototype. In this particular case, this is going to be a long-term functional prototype, which means I am going to leave these composites that are going to be made directly from an impression of my wax up that was verified in the articulator, and I'm going to restore these teeth using this clear PVS. And I'm going to make sure that my composites are a duplicate of what I got on the diagnostic wax up that I created. The idea is that the patient is going to function on these prototypes. These are not my definitive restorations, but they are a long-term option, which means that I can use this for a year or 2 years on my patients if needed. In this particular case, what I was trying to do, I was trying to accomplish what we call the Dahl effect, and I'm going to talk about that just in a couple of minutes, so I'm not going to get into details right now, but because I was going to allow his posterior teeth to over erupt and allow his anterior tooth to intrude a little bit because of the excess pressure of the muscles only on these anterior teeth through these prototypes. I was going to accomplish a full occlusion on this patient. And the reason why I chose this treatment option is because I did not feel comfortable prepping all those posterior teeth and restoring them with indirect restorations just to increase the vertical dimension. I thought that this patient had a lot of healthy tooth structure that I did not feel comfortable just removing. So by increasing the vertical dimension and by fabricating this type of prototypes only on the anterior guidance, I was able to then do no restorations on posterior teeth using that Dahl effect concept, which I will explain in a short couple of minutes. So here you can see I'm acid etching the lingual surfaces of the canines and the laterals, and I'm going to go ahead and bond. I'm going to warm up some of the composite. You can see this is the composite warmer that I use for when I'm fabricating my prototypes for long-term use. I want to use just regular microhybrid composite, which I know it's a very strong material. If I was going to use the prototypes more as an aesthetic prototype, then I would probably use flowable composite, which makes it a lot easier. But if I want to use them as a long-term temporary, 8 months, a year, or 2 years, you want to make sure that you use something as strong as a microhybrid or nanohybrid composite. So I put them on the warmer. Once the composite is very nice and warm, it really flows beautifully inside the intaglio surface of this clear matrix. I injected on the lingual surfaces of the canine laterals and centrals, and then I go ahead and light cure through it. Now you can see that I sat the clear PVS on the maxillary incisors. You can see how I was able to develop exactly the same anatomy that I was able to develop with my wax up on the lingual contours from 6 to 11. And I also want you to see my mandibular incisors. These were all restored. They're all connected together. I don't separate them because, again, these are only functional prototypes. This is what I use instead of using an occlusal splint. Because the problem with an occlusal splint is that if the patient doesn't use it, you're not going to get out of the splint what you're looking for from a clinical standpoint. On the other hand, a bonded prototype, they can't remove it. It's bonded to their teeth. It's permanently there. So they have to use it, and I'm going to get what I'm looking for from an occlusal standpoint out of this splint, because it's none other than a splint that is just bonded to the patient's teeth. So you can see I went ahead and did my prototypes also on the mandibular incisors, and then I started checking the occlusion. Because there are no posterior teeth in contact, all I have to do is make sure that all those incisors, mandibular incisors, are touching on the lingual incisors at the same time and with the same intensity. I have it move forward, left and right, make sure that the mandible moves freely, because there's no interference on the posterior teeth, which is great. It makes it a lot easier for me to adjust 12 teeth than have to adjust a full mouth if I do prototypes everywhere. So you can see here I'm going forward, left and right, making sure that I'm checking everything. And once I do this, this literally takes me 30 minutes on the upper arch, 30 minutes for the mandibular arch. Is a 1 hour appointment to do the prototypes. Maybe I can take 45 minutes more just to make sure that I adjust everything very well, that I polish, that I clean, that I allow an interproximal toothbrush to go in between each teeth so that the patient can have good hygiene at home. And this is the before and immediately after. And what I like about this prototype is that really is not only a functional prototype that is modifying the patient's occlusion, but it's also an aesthetic prototype because it took into account the patient's chief complaint, which was, I don't like this diastema between my central incisors that I did not have just some years back. So you can see that immediately I was able to close that diastema using the same prototype. So not only was it a functional one, but I would consider this also an aesthetic prototype. And again, you can see the before and after opening. The cant is still there. We needed to have this splint to act more as an orthopedic appliance to allow these condyles to the inferior lateral pterygoid to completely release its contraction and allow these condyles to go up the slope against the meningi and fully seat on that bone brace position in centriculation. And while that is happening, that is going to take a couple of weeks, we're going to go ahead and adjust little by little those mandibular incisors. They're going to need some adjustment. Actually, the first adjustment is done 24 hours after we delivered the prototype. And you can see here, we're going back. We needed to do just minor adjustments here and there because the patient was feeling, yes, I'm touching harder on one side than the other. And the reason why he's feeling that is because now that inferior lateral pterygoid is relaxing, the condyles are going up the slope against the meningi, and that's going to change the position of the mandible. That's going to modify, or we're going to need to alter that, kind of start correcting that, because now we have a nice and even condyles at the glenoid fossas. So again, you can see I'm just making sure that everything is okay from an occlusal standpoint. And we saw the patient, maybe 3 times in the first 2 to 3 weeks. Then the patient was, he was to stay home and just call us if he had anything that was bothering him. The patient, they normally feel a little bit different because obviously they don't feel that the posterior teeth are touching, and they all have the same concern. They all ask you, will I be able to chew foods? And all I tell them is, look, every time you're chewing any foods, your teeth are not together. They are apart because you have the food in between them. So you're going to be able to eat just as you did before, and these teeth will start moving slowly, and we will get contact in all posterior teeth for sure. And how do we know that? Well, we know that because we're going to now talk about the Dahl effect. And the Dahl effect is nothing new in restorative dentistry. This is the photos of my patient 8 months later. after 8 months of using this anterior prototype, functional prototype, we were able to accomplish full occlusion on every single tooth without having to restore any of the posterior teeth. And this Dahl effect, the first time that it was ever published, was in 1975 by Dr. Bjorn Dahl from Oslo. And what he did is that he was actually, it was an alternative treatment option in cases with advanced localized attrition. And if you think about this, this is exactly the way I would like to describe my patient. He had advanced localized attrition. So the Dahl concept refers to the relative axial tooth movement that is observed when a localized appliance or localized restorations are placed in supraocclusion and the occlusion reestablished full arch contacts over a period of time. That is what specifically the Dahl concept refers to. And that's what I wanted to accomplish with this patient. Because again, what I wanted to do is I wanted to keep it simple. If you keep it simple and something doesn't go your way, it's very, very easy to solve. These photos were obtained directly from Dr. Dahl's article in 1975. You can see that he did prepare the maxillary incisors, and then he made an impression, and he now fabricated a removable removable appliance that actually was made out of metal, that actually sat on these lingual contours that had excessive wear of the mandibular incisors with a new anatomy, with a new lingual anatomy, which now increased the vertical dimension of this patient. And then he waited for these posterior teeth. As you can see in the middle photo, there is no contacts on the posterior teeth, just like in my case. Now, many of you may be asking, hey, but this is a really, really old technique, a really, really old study. Yes, but Dr. Poyser in 2005 revisited the concept and started looking at the literature and the literature review to see, is this, how many times has it been published, how many cases have been published, how many studies have been out there, and what are the results of this study to 2005. And in his conclusions, he said that the success of the Dahl concept was based on what? The literature reports that the objectives of the Dahl concept are achieved in the majority of cases 94 to 100%, and that this space creation occurs irrespective of age and sex. So I feel comfortable doing this on any patient. And as you can see, when you look at the lit review that they completed, you know, there are newer studies, 1982, 1999, 2000, 2002, and 2003. So this is something that has been continually used and studied, and that's the reason why I feel comfortable not only teaching this but also doing it for my own patients. So I'm going to go back to the starting point of this case. You can see our wax up. You can see how all posterior teeth were separated approximately 2 millimeters on the back. That was the amount of increase of vertical dimension that we established for this patient. And this is 8 months later. You can see how we were able to establish full occlusion on every molar and premolar. And not only I want you to see this on the photo, but we were also able to correct the cant on the mandibular incisors. We were able to orthopedically position the condyles so well in those glenoid fossas correctly, with the correct alignment of the condyle disc assembly, and with both inferior lateral pterygoids completely relaxed, meaning in a full centric relation bone brace position, we were able to even out all those mandibular incisors. We never had to repair any of these restorations throughout the entire duration of the prototypes in the patient's mouth. But I also want to show you this photo, which is worth 1,000 words, because you can see here I am using articulating paper just to refine. I'm using AccuFilm just to refine my occlusion, because he had already contacts everywhere. But I just wanted to make sure that the contacts, if you look at the first photo on the left-hand side, you can see that on the molars, the contacts were a little bit stronger than on the premolars. So I went ahead and I just adjusted a little bit just to refine this occlusion and make sure that I still had canine guidance and anterior guidance and no interferences on any posterior tooth. Literally, this is textbook occlusion put on this patient's teeth throughout this Dahl effect and the bonded functional aesthetic prototype on these anterior teeth. So this is, I think, my last photo. I hope that you have enjoyed this presentation, and I hope that you have a good rest of your day.